One on the left is sort of a proton density, and the one on the right is a T1. Okay, that's enough of that. Post-contrast. And so what's the most likely diagnosis? Are we dealing with an astrocytoma, an ependymoma, metastatic disease, MS, or abscess? So let's do the count. I want to hear the music. I have Festus's hairline, so maybe that's as close as I get. And the answer is excellent, sort of across the board. This is a little bit of an eye shot. I mean, for the lesion within the cord, you are correct that pretty much could be anything. But of course, the eye shot is the stuff that's hanging out in the lungs. So those of you who did metastatic disease, number 3, you were correct. So that's my placeholder in case I get fidgety on the mouse. So just I don't want to give it away. So metastatic disease is the answer. Now remember, cord metastases, not hugely common, but we need to think about those. Fortunately, patients living longer and longer with combined therapies. So we're seeing these type of metastatic lesions. And relative to metastatic lesions, the following are going to be the most common metastatic lesions to the cord, except, and the first time I ran across that on the MOC, what's the most likely, what's the least likely? So the best advice I can give you is actually read the question when you're going through, look at, is it most likely, is it least likely? How is the question phrased? What is the most common except melanoma, prostate, renal, lung, or breast? In your answer. Very good. Prostate, the most infrequent of these metastatic diseases. That's excellent. So of all those, melanoma, pretty good. Lung and breast, just because it's the most common, and just by default, it's going to be the most common that we see within the cord. Melanoma, because it likes the milieu of the cord, for whatever reason, we can see that. Also, renal cell is not that uncommon. I mean, it's a low percentage overall, but as far as the percentage within cord metastatic lesions, it's fairly common. Even for parenchymal brain mets, prostate is uncommon, so it's not something you think about. Many people with prostate carcinoma, we see very few in the way of primary parenchymal metastatic disease to the brain or to the cord. Differential is going to be broad. Again, just as you saw, anything that's enhancing within the cord, tumor, demyelinating, inflammatory, or infectious, that's not of much help. You need the history and look for the ancillary findings. And if we can just go through a few of these lesions, in the cavernous malformation is going to have that typical salt and pepper pattern. You would look for the hemosiderin rim around it. Looks like a cavernous malformation in the brain. Look for associated hemorrhage. If there's more acute symptomatology, you may have some edema, but typically without new symptoms, you do not expect to see much in the way of edema or much in the way of expansion. That also tells you that I'm not going to have a cavernous malformation elsewhere for the other studies that we're going to look at. Metastatic disease, multiple lesions. Here we're seeing both areas of solid enhancement and ring enhancement. This is, at least I classify as a leptomeningeal or sort of penetrating vessel pattern that you might see in lymphoma in the brain. The same type of pattern can occur in the cord when you see these dots and dashes that extend beyond the surface of the cord into the substance of the cord. So lymphoma or leukemia is a good pattern for this dot and dash pattern. Nothing else really much is going to give that pattern. And then MS is always going to be the great imitator. Occasionally you will run into the lesions that are solidly enhancing, have a large amount of edema, fusiform cord enlargement, and at any one time point you're not going to be able to say, is that tumor, is that demyelinating? It's really going to be a matter of time to see the evolution of the lesion. Another example of metastatic disease in a child with leukemia. You have multiple lesions enhancing within the cord and really get an idea of the underlying abnormality of some type of small cell tumor when you see the low signal relatively studding up and down the cord, and then intervening high signal intensity on T2, which is the edema, and giving a very typical edema pattern, sparing the periphery of the cord, coming up, and you have this flame-shaped front as it comes up. Very typical. That's the pattern of vasogenic edema in the cord. We don't see really the fingers coming out into the white matter like we do in the brain, but the equivalent pattern in the cord is that advancing front. Next case, 54-year-old with, guess what?